Good afternoon, my dear colleagues. It's my great honor to introduce the next speaker, Professor Kenich Nakajima. Professor Nakajima now is the professor of the Department of Functional Imaging and Artificial Intelligence at Kanazawa University. And maybe many of our colleagues have known Professor Nakajima very well. He has been a very excellent and well-known nuclear cardiologist, not only in Japan, but also in the world. Professor Nakajima was ever being the president of the Japanese Society of Nuclear Cardiology. Now he is still very active in the research of the field of nuclear cardiology, especially in the on the MIBG studies. In previous talk, we know how to calculate the standardized MIBG HMR ratio. And in the following talk, Professor Nakajima will further talk about how to use this standardized MIBG index to the diagnosis of cardiology and the neurology disease. Let's welcome Professor Nakajima.
Thank you very much for your kind invitation to this symposium. We are very pleased to collaborate with you for standardization of MIBG parameters. And today I'm going to talk our clinical results, how standardization has been done in the clinical practice of cardiology and neurology. Today I'm going to talk on first, importance of standardized approach and the effect of standardization on normal database, optimal diagnostic cutoff, comparative or multi-center studies for cardiology and neurology, and finally, application of standardized MIBG parameters to risk models. As you know, on the right side, you can see, MIBG and norepinephrine has very similar structure, and the quantification of sympathetic activities has been done in various ways, but heart to mediastinum ratio has been most commonly used. So here, MIBG planar and spectral images or polar map is shown here. And planar HM ratio is still standard quantitation method for a long time for heart failure study, diagnosis, and mortality prediction. And for Lewy body disease, for the diagnosis of Lewy body dementia, Parkinson's disease, and so on. And however, inter-institutional differences significantly influence the threshold values. Therefore, it resulted in ambiguity for diagnostic and prognostic analysis. Therefore, we decided to standardize the H2M ratio some years ago. So let's see image quality of MIBG. Planar image is not so much different, of course, but as you see on the upper side, this is angle camera image, a 20 minutes acquisition. It was actually obtained in 2005. We can see significant innervation defect in the lateral wall, as shown here. Image quality is not bad, even from the viewpoint of the present conditions, but now, when we use D-spec, it's 10 minutes acquisition. The one wall is very thin and clearly visualized. However, when we use MIBG with D-spec, we must be a little bit careful about the reconstruction method. When a defect is large, particularly in the inferior wall, or in the apex, caution is needed for SD reconstruction. SD reconstruction is heart prior model, assuming the shape of the anatomical model, heart model. Therefore, for example, in here, as shown here, OSM reconstruction is okay. It's ordinary. We have seen these images, but in SD reconstruction, the inferior wall is erroneously selected here. Therefore, when usually SD reconstruction works, but when it doesn't work, we must use OSEM reconstruction. Anyway, standardized H2M has been applied to various multi-center studies, both in neurology and heart cardiology. For example, in EJ&MMI, AD versus DLB differentiation, and this is multi-center study on DLB, which was published in 2015, and in heart, in a Japanese study and European studies such as appropriate ICD therapy and MIBG for CRT response. This is summarized in Amsterdam University. And now, most of the neurology and cardiology studies use the standardized HM now in Japan. So, what about standard protocol for acquisition? JCS, Japanese Circulation Society's guidelines summarize pre-treatment and imaging technique like this. It's written as a thyroid block is not essential. In many European countries and in the United States, thyroid block might have been done, but we don't use it. However, discontinuation of tricyclic antidepressant or antipsychotics is definitely necessary. Please be careful. And the dose is 3 millicurie of MIBG, and early imaging and late imaging from 3 to 4 hours are routine procedures. Now, let's see MIBG in guidelines and criteria and the academic societies works. In Japan, the Circulation Society's guidelines, which was published in 2012, first indication is heart failure and prognosis. It's a class 1 recommendation. And heart failure treatment is also included. And EANM Cardiovascular Committee and European Council of Nuclear Cardiology included proposal for standardization of MIBG, but this standardization is not phantom-based, of course. And Japanese Society of Nuclear Medicine Working Group summarized normal database of planar and SPECT studies, and which is published some years ago. Then Movement Disorder Society, clinical diagnostic criteria for Parkinson's disease included MIBG as supportive criteria for Parkinson's disease. And as you know, in the fourth consensus report of dementia with Lewy bodies, DLB consortium included MIBG as indicative biomarker of DLB, which is published in Neurology 2017. And ethnic guidelines, which was published in 2016, has the comment like this: potential indication of MIBG for ICD candidate for sudden cardiac death. But still, it's ongoing whether it's really useful or not. In Japan, 2018, JCS guidelines for chronic heart disease coronary heart disease was revised. And in that guideline, recommendation and levels of evidence for prognostic evaluation by MIBG imaging is prognostic evaluation for ischemic heart disease. 2A recommendation, meaning that the weight of evidence and opinion is in favor of usefulness. However, because it's a consensus opinion of the expert, level is C. But usually in Japan, it's very widely used. What about total number of cardiac studies, nuclear cardiology studies in Japan? This is a summary of 2017, and we may have new statistics from now on. But anyway, at that time, Thorium-201 is in 44%, and technetium-99m perfusion tracers in 35%. And please note MIBG in 15% of the nuclear studies. Actual number is shown here. Anyway, the I-123 tracers such as MIBG and BMIPP is in 20% of the studies in Japan as a nuclear cardiology. So, what about normal values or HM ratio in the control groups? When we look at the control groups, HM ratios are shown like this. When we look at the mean and the standard deviation, the lowest one is 1.88 and the highest one is 2.87. So if we use mean minus 2 standard deviation, the lowest one is 1.4 and highest one is 2.0. Anyway, we can note a very wide range of distribution, even in the control subjects. It's similar in Europe and the United States. For example, when we look at these images, the lowest one is mean value of 1.7, and the highest one is 2.5. And mean minus 2SD is, this lowest one is 1.8, 1.08 is too low, and the highest one is 2.0. And actually, you may notice collimator differences. Probably this is HR, and this is ME collimator. As you may have noticed, if we use ME collimator, HM ratio will be calculated higher. It's similar in the washout values, quite a wide variation in the literature. And the mean value will be from 10% to 35%, but some are background corrected, some are decay corrected. It's not so uniform. So we must be careful about the calculation of washout rate also. In 2010, Admire HF study was performed, and in JAK, it's sometimes used or cited. HM ratio of 1.6 is the threshold for good and bad prognosis, even for arrhythmic events or cardiac death or progression of heart failure. In any cases, 1.6 can be used. It's their final conclusion. At that time, still there are so many variations. For example, Merret, France, shows that the threshold for HM for poor prognosis is 1.2. By Dr. Nakata, it's 1.74. And Dr. Jacobson, from, as I have seen, it's 1.6. So in these backgrounds, we thought standardization is absolutely necessary. So the phantom calibration was, phantom was made in 2007. This point is explained in the previous session, so you have seen it. And the multi-center cross calibration was tested in 2014, and later in 2017, European myocardial, MIBG cross calibration phantom study was added. And now we may be able to add experiences in Taiwan. So what about the effect of standardization on normal values? Before correction, since the database included LE collimator and ME collimator and in the various vendors, therefore, there's no correlation between the age and the H2M ratio. However, after standardization of H2M ratio, we can note that the HM ratio is gradually decreasing with age. If we divide patients, for example, less than 63 and more than 63, this is median value. For early HM ratio, the mean value is 3.2, and for more than 63 years, it's 3.0, and for late HM, in the younger patients, it's 3.4, and older patients, 3.1. But we can note that so even in younger patients and older patients, H2M ratio of 2.2 might be used. Or of course, we must be careful about the interpretation, but the threshold value is around 2.2 for both early and late images. So if we summarize normal value in Japan, probably these values are true for Taiwanese, and now the RE standardized HMR normal lower limit is 2.2. Here late, it's a 2.26, so almost 2.2. And as for the washout rate after background and decay correction, 34% or 30% around here. Now we can see a threshold of 1.6 again. For example, here is Admire HF study, and some Japanese study shows higher values like 1.7. And if someone uses MEGP collimator, the threshold might be 1.9 to 2.1, 2.0, but it is actually the same condition. The difference is only collimator and vendors. Appropriate database is also essential for defect scoring. Taking this patient as an example, inferior wall is low, but this is Japanese Society of Nuclear Medicine normal database. We can note higher variation or deviation here. This is mean value and this is deviation. If this kind of database is applied, basal segment is not abnormal, but we can definitely count defect scores here. For example, this image is made by D-SPECT and a female patient with heart failure. We can see significant defect here in the delayed image. But in order to apply defect scoring, we need new normal database. We are now creating new D-SPECT databases, and it will be probably finished within this year. Multi-center prognostic studies using standardized data is summarized like this. Although I might have shown this slide so far, the total number of patients is 1,300, and that included collimators of LEHR, LEGP, and LME collimators. Therefore, we have to correct it. And by accumulating all the data, for example, patient with HMR more than 2.1, 1.4 to 2.1, and less than 1.4, the prognosis, mortality is quite different, clearly differentiated. Particularly when the HM ratio is less than 1.4, 10-year survival is only 50%. We can also see 1-year, 2-year, and 5-year mortality rate. Now we can see a significant increase of mortality like this, and particularly when HM ratio is less than 1.6, it's much higher. So let's see, 2 patients with dilated cardiomyopathy. We made risk model to calculate or estimate risk for death or severe events. This patient is a 54-year-old male, DCM, ejection fraction 19%, and HM ratio is 1.6, and NYHA class 3. And this patient, risk value is very high, 50%, and actually he had CRT device implantation after that and experienced a VT episode. Here, this is a female patient, ejection fraction is similarly low, but HM ratio is so normal, and NYHA class 3, but estimated event is very low, and actually she didn't have any event after that. What about the accuracy of validation, accuracy of 2-year risk model? This is validated by us using 546 patients. And so risk value, 2-year risk value is divided, classified into less than 5%, 5 to 8%, 8 to 14%, and more than 14%. And so red box plot is actual calculation in each patient, and blue is actual cardiac death. There seems to be a good agreement when we compare the prediction and actual death. Subsequently, Dr. Tamaki from Osaka University summarized this risk model in an acute decompensated heart failure. They also showed that the correlation between predicted value and actual death is in a clear relationship. When they divide it into low risk less than 4%, intermediate risk from 4 to 12%, and more than 12% as a high risk patient. In addition, although we made artificial intelligence technique, machine learning, for predicting survival, fatal arrhythmia, and heart failure death, we need to use MIBG H2M standardization and age, sex, NYHA class, ejection fraction, renal function, hemodialysis, hypertension, diabetes, BNP, and so on, anemia. These are included, and we try to predict these outcomes separately. So when heart failure death probability, predicted heart failure probability is more than 15%, actual death is definitely high for heart failure death. And when arrhythmic event probability is high, the results are again so good. It can be clearly predicted. And when both are high, heart failure death and arrhythmic event is high. And when both are low, actual event is very low. Therefore, depending on such kind of classifications, for example, here, CRT may be indicated. In this case, ICD for the prevention of the arrhythmic death might be indicated. Here, CRTD might be indicated. And here, no device might be indicated. Bell-shaped relationship between MIBG H2M ratio and the event rate has been noted in some studies, and it's from the Amsterdam University. We can see that the sudden cardiac death and appropriate ICD therapy is shown here, like this. So I calculated the similar condition based on the similar condition machine learning model here. This is NYHA class 3 predicted, and this is NYHA class 3. This is class 2. So we can note very similar relationship between this one and prediction. This sort of simulation might be done machine learning, but we need to be careful about the future applications. So using basic conditions, risk might be estimated for heart failure death and sudden cardiac death separately, and depending on risk values, we might be able to indicate some kind of treatment strategy from observations, optimal medications to cardiac device, and so on. Now, we are going to see neurology study. So in DLB consortium guidelines, it says MIBG is an indicative biomarker for DLB. Usually reduced dopamine transporter uptake is included, has been included, and at this time, MIBG was newly included. And the image included in the guideline is shown here. It's from Kanazawa University. And heart-to-mediastinum ratios are standardized to the values comparable to MEGP condition. Usually, for the diagnosis of DLB patients, visual assessment is not bad. It's good. For example, it's normal. On the right side, it's low. And in intermediate case, it's some activities shown here. So it's intermediate. HM ratio is 2.4, 1.8, and 1.5. And when the images are interpreted by cardiologists, neurologists, and nuclear medicine physician, the visual impression is normal, probably abnormal, and abnormal. It's not bad, but there are some borderline interpretations here. But if we use H to M ratios around here, it seems to be clearly separated, except for very exceptional cases. And diagnostic guidelines for Parkinson's disease 2018 in Japan raise the question like this: is MIBG scintigraphy useful for the diagnosis of Parkinson's disease? It's yes. It's useful for differentiating Parkinson's disease and other Parkinson syndrome. And sensitivity and specificity are more than 80%. And in that statement, standardized H2M ratio was reported, and the standardization is ongoing in Japanese hospitals. It was 2018, so now it's almost finished. However, appropriate H2M is still variable even after standardization. I would like to note it. Cardiac MIBG normal uptake values are population specific from the patients over 60 years of age. This is reported from UK, and they said HMR cutoff values are lower than in Japan and higher than in a large US study, but similar to those found in another UK center. It's their study. This is UK guideline, UK threshold, and Japanese threshold. So they said UK value is better. Now, so I asked him, her to send me the original data in order to write an editorial and compare the results. When we look at the controls, UK patient more than 60 is 2.7, and in Japan, more than 60, 3.0, and in Japan, less than 60 years old is 3.2. Similarly, in AD and DLB in RHM ratio, in UK, AD and DLB is 2.5 and 1.9, but in Japan it's 3.1 and 2.0. UK data were also standardized using the same phantom study. So how can I understand such differences? There are some factors possibly affect the thresholds. For example, age and sex and the background of the patients, like coronary artery disease, diabetes, and so on. In Japanese studies, a Japanese multi-center study, so complications are carefully excluded. But in the UK study, these are included. So background is a little bit different. And another point is obesity. In Admire HF study, mean BMI is 29. In the UK, it's 28. And in Japan, it's 22 to 23. For example, if we see German study here and the Japanese study here, you might be able to see the scatter of the photons around the body due to obesity here. This sort of differences might be also concerned. Therefore, in UK, when we write the probability of DLB and AD, UK probability is like this, and in Japan, it's something like this, and it's more steep around the threshold of 2.2. The standardization is also useful to compare institutional data or your institution to published data. This is an example. It's from Kanazawa University. But anyway, the H2M in the manuscript is like this: DLB, Parkinson positive and negative, and control and AD. But if someone use MEGP collimator, then it should be interpreted like this. Particularly, the difference is large for control patients, 2.2 versus 2.6, and 2.2 versus 2.7. So we can interpret in any ways depending on the your institutional conditions. Even when the camera was renewed, we can combine all data. This is also important. This is a case in Kanazawa University. Until 2008, we used LE collimator. Therefore, it was 1.97 for non-LBD Lewy body disease and 1.4 for Levy bodies. But after 2009, H2M ratio is suddenly increased. Therefore, we decided to standardize all the data to standardization to MEGP conditions. Then we can combine all the data and long follow-up study can be completed. MIBG, myocardial scintigraphy for the diagnosis of DLB, was first studied some years ago, and the initial report was made in PROS 1 using the 133 patients. At that time, patients were classified into probable DLB and probable AD and possible DLB. And the initial analysis was done, and the baseline ROC was in the gray line like this, AUC of 0.84. And 3 years later, the diagnosis was made again. Therefore, some of the patients were converted to different types. Probably this is the correct diagnosis after the 3-year follow-up study. And then the ROC AUC increased to 0.92. MIBG study was performed only once in the beginning, therefore, this means MIBG study was actually right. So, in summary, MIBG standardization is essential for various clinic settings, and we have used it very conveniently. Creation of normal database, including various centers, are very convenient for clinical practice. It can be also used to determine the threshold for poor prognosis for heart failure patients. And to determine the threshold for Lewy body disease, like dementia Lewy bodies and Parkinson's disease, and to compare, sorry, this is mistake, compare previously published data to institutional data. And finally, when a camera is renewed, we can use all the data. By such MIBG standardization method, a worldwide database can be created, although patient background needs to be adjusted. I'm very happy to be able to share these results, and good cooperation make progress from now on between Taiwan and Japan. Thank you very much for your attention.
Thank you so much, Professor Nakajima, for the very comprehensive review on so many important and practical issues regarding standardized MIBG index. Now we have already many questions from our audience. Professor Nakajima, can you see the questions?
Yeah, okay. Thank you very much for invitation today.
We start from Professor Wu, Wu Yanwen. How to define the different significance of a regional defect?
Yes, okay. So it's sometimes asked whether how we can use H2M ratio in patient who has both cardiac diseases and neurological diseases. So I'd say that it's actually very difficult when a patient has a Lewy body disease or Parkinson's disease. Therefore, in order to interpret the images, we must be careful. But actually, the distribution of the MIBG is a little bit different. For example, in a DLB or Parkinson's disease, the uptake is generally decreased in all wards. But in heart failure patients, it's of course depends on the patient conditions. And when a patient condition is severe, then it might be so heterogeneous, or anyway, we can see some activities in the heart. Therefore, there are many intermediate H2M ratio. But if the patient has Parkinson's disease, Lewy body disease, unfortunately, we cannot differentiate the conditions or prognosis or diagnosis based on MIBG.
Professor Wu, did Professor Nakajima answer your question? We have more questions from our audience. The next question is regarding initiation, progress, and the application in the MIBG standardization. This is Jilongchangeng Memorial Hospital. Any correlation of MIBG distribution and the MACE or survival? MIBG distribution.
You mean it's in neurological patients or more generally?
I think he's asking heart failure patients. Yes.
Yeah. Sudden cardiac death or heart failure death might be predicted if we use machine learning, but if we simply use statistical model, it's a little bit difficult. One of the reasons is that sudden cardiac death has the, as I have shown you, bell-shaped appearance. Therefore, in patient who has intermediate H2M ratio, the sudden cardiac death probability is increased. Therefore, such kind of correlation or relationship cannot be well estimated by statistical analysis or conventional logistic model. But the similar question might happen from the audience that if the neurological patients are included. In that case, probably we need to make another variables other than the MIBG. For example, we have also studied about some other possibilities, for example, such as phase dysynchrony or echocardiography or electrocardiogram and so on. There are many variables related to heart failure. Therefore, some other methods need to be considered. But anyway, if the patient doesn't have any severe complications, MIBG will be very conveniently used. Is this okay?
I think it's okay. Is there any more questions? I have a question to Professor Nakajima. I'm quite interested in your artificial intelligence model of heart failure. We see MIBG standardization index is an important factor among so many index. But I'm curious, usually patients receive an MIBG scan also have myocardial perfusion scan. Why did not perfusion index added in your model?
Yes, it's very interesting because we have accumulated many patients, more than 1,000 patients, which only has MIBG. We couldn't include a perfusion defect or possibility of ischemia, or as you have studied and published in JNC or another nuclear medicine, such kind of dysynchrony might be also used for the new models. There are many possible approaches for the estimation of cardiac risk or mortality risk. Of course, we may be able to input everything into the model, but total number of patients is, for example, around 1,000 or so. Therefore, too many variables confuse the model. Therefore, we cannot perform it still now. But I think it's very promising approach. Thank you.
Okay, thank you. We have one more question from Dr. Men Chaoyang. He asked, sudden death rate in DLV will be increased if low MIBG showed more in follow-up patients? Can you understand the question?
To predict sudden cardiac death, that death rate cannot be, predicted death rate cannot be more than 50%, as you might imagine. For example, the sudden cardiac death is more than 10%, it's sufficiently high. In those patients, and if the patient has low ejection fraction or heart failure conditions, for example, ICD or CRTD might be indicated, or more careful follow-up will be necessary. On the other hand, if the patient risk is less than 1% per year, the death rate will be very low. Therefore, it might influence the medications of the patients or follow-up interval of the patients. But probably it depends on the cardiologist. And although I would like to apply it to clinical practice by cardiologists, I would like to recommend some possible use of this kind of models.
Okay. Okay. The next question is from Dr. Zhang Yangpei. He asked, would you recommend regular follow-up in patients with neurodegenerative disease such as DLBP and PD to reach the definitive diagnosis?
In patients with DLB or Parkinson's disease, H2M ratio is definitely low from the early stages. Therefore, even if we follow up the patients in patients who has neurological problems, the changes might not be so significant. Therefore, it may, in addition, the low H2M ratio is not directly not related to cardiac event risk. Therefore, in a patient who has neurological disease, a prognosis should be considered from the different way. Yeah.
Okay. Okay. I guess it's the final question from Professor Wu. In your talk, we could see the CCT scanner has improved image quality. So you perform MIBI, MIBG, DISA.
Yes. So simultaneous acquisition. Yes. Actually, we don't. So the reason is, it can be one approach, particularly when we use a D-SPECT or it might be GE camera. But anyway, dual energy acquisition can be done more reliably. But in those patients, MIBI has been done before MIBG study in most of the patients. So we don't use the dual energy acquisition. But as he says, the information of the perfusion of the MIBG in the same patients will be very convenient to understand the perfusion defect or innervation defect. So in any ways, it's usually necessary to compare the patterns of MIBG defect and perfusion defect. If you can obtain the images simultaneously with, for example, D-SPECT, CCT camera, total dose of technetium-99m MIBI might be reduced, for example, 5 millicurie or so. So it can be a good method if we can simultaneously do it.
Okay, thank you, Professor Nakajima. Great talk and very detailed discussion with our colleague. But due to the time limitation, we have to close this section, unfortunately. But I guess we still we still have many chance in future to exchange our idea and the collaboration. Thank you.
I hope so.
Thank you again.
Thank you very much.